auscultation. Posteriorly, the nose opens into the nasopharynx. So to examine the nasopharynx, conventionally what we have to use was what it was called as posterior rhinoscopy. Nowadays we have got fibro-optic nasopharyngoscopes, and under local anesthesia, while in OPD setting, we can use that fibro-optic nasopharyngoscopy, and we can anteriorly go, we can examine whole of the nasal cavity, and we can go into the nasopharynx and we can check it out. But before the advent of nasopharyngoscopy and before the advent of even CT scan, it was literally difficult examination to look for the nasopharynx. But still, they do ask you in the examination, and as a step, you have to know how we can do posterior rhinoscopy. Now, posterior rhinoscopy, directly we cannot visualize. So what we have to use a mirror. You can see this is a mirror, okay, and it has got a step here. So why this step is there? In laryngeal examination, there we use a mirror which has got a straight limb. There is no step in that. So here it is a step because we have to look upwards and we have to hold it. For example, instead of this step, if it would have been straight, our own hump of our hand will be hampering our view. Because this time we have to go through the mouth. And this mirror will be there behind the uvula. Behind the palate, we will throw the light here. From here, the light will be reflected upwards towards the nasopharynx, and those nasopharyngeal structures, they will be lit up, and we have to examine that. And as I told you, it is one of the most difficult clinical examination, and within few seconds you have to go far, and even still you may not be able to gather the information. And that was the reason that nasopharyngeal sometimes patients were subjected under general anesthesia for nasopharyngeal examinations. But now, as I told you, now we have got different tools like fiber-optic nasopharyngoscopes, and then CT scan and MRI is also available. So that has made our lives a bit easy. So conventionally we have to use that. During procedure, the patient is breathing, of course. So due to the breathing, this mirror will be fogged. So to avoid that fogging, we have got what we call as anti-fogging solution. If we have got that anti-fogging solution, just put one drop here so that the mirror will not be fogged. If that is not available, then you have to use this conventional, this spirit lamp. Okay, you will lit it up, and then you will warm this mirror from mirror side. By the way, this is called posterior rhinoscopy mirror. The mirror which is with the limb, and you can see the size of the mirror is different. Even in children, you see. And how you can very well imagine how much you would be able to look far into the mirror. That's what I am reiterating, that it used to be very difficult. But still, according to the size of the, you can say, oral cavity, oropharynx, and you have to use this. So you will warm it so that it is not being fogged. So you will warm it from your, for example, the spirit lamp is working. So you will warm it from the mirror side, not from this metallic side. Because if you are warming it from the metallic side, it will dilate and this mirror may fall down. So from mirror side you will. And in the flame, you know that flame has got different parts. Which part of the flame is the hottest one? You know, in the center there is a blue, then outside is the yellow, then outside is one invisible portion from your physics knowledge. Which part is the hottest one? No, the outer invisible part is the hottest one. So just at the outer invisible part you have, because if you go deep inside on the blue or yellow, it will blacken your mirror. So outer invisible part of the flame is the hottest one, and you have to keep it by this rotatory motions just there, okay? So you will just warm it, not heat it up, because it may burn the tissues inside. So you will warm it, and when you are warming it and patient is watching, naturally the patient will be horrified, especially the child. He will never allow you. So what you have to do, you have to check it from metal side on the back of your hand, that it is comfortable for the body or the tissue. So it should not be overheated. So once you have done, then you will take this metallic tongue depressor it is warmed, checked, and then the instructions to the patient will be that during this procedure, first reassure the patient that it is not going to harm him. You just have to examine the nasopharynx, and patient should continue breathing through the nose. Through the nose, not natural breathing, because when he will be breathing through the nose, soft palate will go down, and nasopharynx will be a wider one, so that more easy to examine the nasopharyngeal pharynx. So again, as I told you, you will go through the oral cavity. We have to go. So you will go over the tongue depressor and you will slide it behind the soft palate, and then you will, your light will be reflecting from the mirror, and then you can move the mirror to see the lateral wall of the nasopharynx, anterior wall and posterior wall, and this is how you will go for examination of the nasopharynx. And as I told you, this is one of the most difficult and you have to do it quickly. So this is, so the key for posterior rhinoscopy is this posterior rhinoscopy mirror with a stem, then metallic tongue depressor you have to use, and your patient will be breathing through the nose during the procedure. So once we have done this posterior rhinoscopy, then we will go for physiology of the nose. Okay? Cosmetically we have seen at the start external nose, and then we will see that airway is, because it is mainly, its purpose is for as an airway, so we have to go for any obstruction is there or not. For that, again we can use this tongue depressor. So you can see the fogging is there. Okay, you will ask the patient to take deep breath and then expire it, and you will see, and you can see the fogging over the metallic tongue depressor on both sides, whether it is equal on both sides and then whether it is decreased or not. Okay, but during summer season it will not be fogging at all, because here temperature is so much high. So at that time what we can do, we can take a wisp of cotton, very thin cotton, and that will be, we can ask the patient, just make it thin, close one side, and you can see the movement of this cotton wisp. So you can see the movement, so that clinically you have checked that airway is patent. Okay? Then another function of the nose is smell. For the smell, in the books I have read that there is olfactometer, and different smells can be checked by that olfactometer. But usually this is not available and I have not seen anywhere. So what is the alternate? Alternate is that you can go for any object which is familiar with the patient. It should not be pungent. It is not like that you should bring ammonia and ask the patient to, it will start sneezing, and so it should not be. In your, that small bag which you prepare for your exam. For example, you can bring some small perfume bottle. You can take a small piece of soap, a flower, anything which is familiar to the patient, you can. But the key is, first thing is that you will just tell the patient you are going to make him smell something, and he should tell you what it is, or simply you can say whether he can smell something or not, because sometimes it may be difficult for the patient to pick up what particular object it is. But the key is, while you are doing this, one thing is patient's eyes should be closed, so that he must not be aware of what it is. Second thing is, nasal cavities one by one. Because if we make him smell and he says, yes, I can smell, you don't know whether it is unilateral, because if there is a unilateral problem, he may be, having a smell from other side. So key is eyes closed, and one by one you have to check it out. Okay? मैं आपको कुछ चीज स्मेल के लिए दूंगा, आपने बताना है मुझे आपने. Okay? आप आंखें बंद करें. So he has closed his eyes, then I will pick up whatever. For example, I have got this thing, for example, like this, anything, it may be a piece of soap, or it may be, some smell is there. Eyes are closed, one nasal cavity is blocked, and then you make him smell तो किसी चीज की smell आ रही है कि नहीं, and then you close the nasal cavity and then you can go for other one and you can ask the patient. Okay, so the key is eyes closed and one by one. For respiration, when airway is being checked, no need of eyes being closed. Okay, so after that, just in the start someone said that someone may be having nasal problem actually, but may be presenting with the ear complaints. So we have to check the ear. For the ear, straightforward, when we will do the ear examination, there you will see we will go systematically, so many steps will be there. But as a part of nasal examination, just straightforward you will go for what it is called as otoscope. Okay, and you will do the otoscopy. Simply I will do it. What is the complete procedure, how to hold it, and what we have to look for when we will do the ear examination. There I will, tell you the details. नाक बंद करके जरा मुंह में हवा, हाथ से नाक बंद कर, हाथ से जोर से मुंह में हवा, ठीक, जोर से, दूसरा नाक बंद करके मुंह में हवा, छोड़ दे. So once you have done this, then you will go far, because the patient may have come to you with faciomixillary injuries, isn't it? And in faciomixillary injuries, fifth nerve is also at risk. Okay, because the sensory supply of the face is from trigeminal nerve, motor supply is from seventh cranial nerve. So for that, you have to check the sensations of the, and you know that the face is being supplied by three branches of trigeminal nerve. Okay, and they have got the different territories. So again, you will tell the patient that what you are going to do, and then you will see the response. मैं आपको कोई चीज़ आपके फेस पे टच करूँगा, जब भी आपको लगे तो आपने मुझे बताना है कि वो चीज़ लग रही है कि नहीं. आंखें बंद कर लें सर. आंखें बंद करें. टच हुआ तो जी सर. यस सर. यस सर. यस सर. यस सर. यस सर. Okay. So this is how you will check it out. Okay. What is to notice? You have to check horizontally, not vertically. Okay, what are those three branches of trigeminal nerve supplying this? So first you will go for ophthalmic on this side, then ophthalmic on that side. Okay, then maxillary on this side, then maxillary on this side, then mandibular on this side, and then mandibular on this side. Okay, so this is how you have checked the sensory supply of the face. Okay, so once you have done that, then as I told you, as a part of nasal or throat or ear examination, we have to check the lymph nodes of neck. There are different levels of lymph nodes, so we will go for that. And mind you, initially we have exposed our patient. Now this is the importance of the patient, that up to the tip of the shoulders, your patient is exposed. Okay, so now you will go on the back of the patient. Okay, and you will do the superficial palpation. Okay, and then you will go for deep palpation. When I say deep palpation, that will be with the pulp of your 4 fingers, and you will be palpating different groups of lymph nodes. The lymph node groups: submental, submandibular. Okay, then with the thumb, pre-auricular, post-auricular. Then just flex the neck. This upper deep cervical along the interior border of sternocleidomastoid, middle deep cervical, then lower deep cervical, then come in the midline for pre-tracheal and pre-laryngeal lymph nodes, and at the same time suboccipital lymph nodes with your thumb. After that, you will go for supraclavicular lymph nodes. Okay, this is how you will complete the lymph node examination. Okay, detailed neck examination, when we will do the throat examination, there we will go for, because in addition to lymph nodes in neck examination, we have to look for laryngeal examination, we have to go for thyroid examination, we have to go for the neck as a whole, any swelling if it is there like this. Okay, so here only for lymph node examination, so these are the different lymph node groups which you have to check it out, and then you will re-drape your patient. Sometimes what happens in examination situation, of course you are the tense, you are doing your examination, in between examiner asks you, okay, tell me what you have done or what are the findings, this and that, and you leave your patient and you just jump over to that. That is a very bad thing, because patient doesn't know that examination is finished or not. Okay, so you have to re-drape your patient and then say thank you to your patient. Okay, thank you. So just very quickly, I will brief the nasal examination. To start with any examination, we have to go for introduction, consent, exposure is very important, and then position. After that is the inspection, palpation, percussion and auscultation, if it is required. Okay, examination of the nose, external nose, inspection, then palpation of the nose, supra and infraorbital margins, paranasal sinuses, then we will go for nasal cavity, anterior rhinoscopy without speculum, anterior rhinoscopy with nasal speculum, that is Thudy's nasal speculum, then you will go for posterior rhinoscopy, and then we will come to the examination of the physiology of the nose. So we will go for airway patency, that airway patency can be checked with metallic tongue depressor, we cannot use the wooden tongue depressor. Okay, and then or we can use with the wisp of cotton, and then we have to check the smell. After smell we will go for otoscopy, we have to check the sensations of the face, and then we have to check the neck for lymph nodes, and with that we come to end of our nasal examination. We have to re-drape our patient and we have to say thank you to your patient.